Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning. Thank you, Dr. Sarah, for the kind introduction. Also, thank you to the organizer for inviting me to be here today. I'm just going to go straight to my slides. First disclaimer, I'm a clinical pharmacist. I'm not a clinical epidemiologist. So, but the difference between pharmacists and clinical and non-clinical pharmacists is that clinical pharmacists, they provide direct patient care. So, by the same token, clinical epidemiologists, they provide direct impact of the epidemiology to the individual patients. So, I hope everybody understands that concept. If I get it wrong, then it's my fault. So, any clinical epidemiologist here can correct me. Okay. We go down, isn't it? Okay. So I'm given this topic to share a bit on trends, burden, and implications for care. So this will be the outline of my presentation. I think all of us know in Malaysia we still have a high prevalence of tobacco use, given the increasing prevalence among e-cigarettes especially. That is a particular concern among the adolescents. Although we are seeing for the first time a reduction in conventional or the regular cigarettes, what people call it here, the regular combustible cigarettes too. First time that we have the adult prevalence below 20%. By the National Health Survey, we're seeing that of 19% according to the NHMS 2023. However, despite the reduction in the percentage, we still have a high number of smokers. Yeah? So, that's, compared to the global scenario, which is about 1.3 billion from the WHO data, it's still high. Every single user is of significance because it contributes to the potential of premature death and diseases. And there are at least 8 million deaths per year globally that has been attributable to tobacco burden. Smoking has always been and still is more prevalent among the males. In certain countries, you may have similar prevalence. I probably think about Eastern European countries or Turkey. Yeah, even the women prevalence is similar or just a bit lower than men. But globally, men smoke more than women. And with the advancement in many areas of tobacco control, we're seeing majority of smoking is now in low-income and middle-income countries, and unfortunately Malaysia is one of those countries. Okay. The work remains because as in Malaysia, the global trend in smoking is also declining. Okay, but I've mentioned be cautious to read the percentage versus numbers, the actual numbers of smokers. So, because of population growth, we are still seeing a significant number of smokers worldwide, and also in the region. We are in WIPRO, Western Pacific region, under WHO. I don't know why, but we are in Southeast Asia countries, so when we look at CRO, also this is where the high prevalence of smokers are. Okay. So I mentioned about the good news from the 2023 National Health Survey and the Global Adult Tobacco Survey. We're seeing the first time prevalence below 20, so it's 19%. About 4.8 adult smokers, yes, still high. Okay, majority in the males are still increasing among the females to a certain extent, but particularly in terms of vaping issues. So this is the dual epidemic that we are facing in Malaysia right now. We try to control combustible cigarettes, seeing some improvements. Unfortunately, the other epidemic in terms of vaping is coming into this scenario. So from the Global Adult Tobacco Survey, okay, we found that about 1.4 million currently using e-cigarettes, okay, and the most concerning part is the increase in prevalence among the youth. Because of that, we're also seeing increasing percentage of dual use, meaning that people who smoke conventional cigarette and they also vape. Okay. Alhamdulillah, another good news is the standalone tobacco control of smoking products for public health, or the 852 Act. So that has been put into force October last year. Okay, so now we're hoping for more implementation and enforcement of the act, because having an act is useless if it's not enforced, as you know. Okay, so we'll try to make sure that by reducing the prevalence, we will reduce the burden associated in terms of diseases and death. As mentioned just now, at least 8 million globally, but in Malaysia it's at least 20,000 deaths related to tobacco use. The majority is from the cardiovascular, ischemic heart disease, but we also have respiratory and cancer and cerebrovascular, especially stroke. But as you know, smoking can cause more than 20 diseases. So these are just the top causes of death among smokers in Malaysia. Okay, so the risks are all established in terms of causality. So the knowledge about association between diseases and smoking has been well established. Now more evidence is becoming more established for vaping as well. Okay, you know the initial story from the e-cigarette industry, or the proponents or the supporters of e-cigarettes, they use the 95% less harmful, but unfortunately we know that those are really unsubstantiated. They are really tobacco and e-cigarette company influence. They are based on weak science and blah blah blah. So now nobody can say that it is 95% less harmful than cigarettes anymore, because evidence emerging saying that e-cigarettes also associated with cardiovascular, respiratory, and latest one is cancer. So very similar to what we are seeing with cigarettes. And other than this three, all the clinicians here, please don't forget other diseases in the 20 diseases list. Sometimes you only think about bringing up the issue of smoking if you're seeing patients with respiratory, cardiovascular, and maybe cancer. But don't forget, even our, I would say number one, NCD, diabetes, it can be made worse by smoking, as well as other diseases. So if you are a clinician, a healthcare practitioner, regardless of whatever disease you are addressing, there's a probability, high probability that in the smoker is this associated. Okay? So you need to address that. And with the diseases, it comes with the economic burden. So it can be direct and indirect costs. The pharmacoeconomists would really love this, the healthcare burden, the quality adjusted collies and dailies, all those numbers would come into play. But I would say that this is very straightforward. This is very logical. You have at least 4 million smokers. They are having multiple diseases. If not one of those three, it can be any of the 20 plus diseases. And if they seek treatment from the government-based facilities, they are going to eat up the budget from the Ministry of Health that is largely contributed by taxpayers. all of us we are supporting the treatment of smokers in various diseases at various government facilities. So it eats up a huge chunk of the GDP, costing at least 6.7 billion in estimated annual direct and indirect costs. So which brings to the interesting fact regarding collection of taxes. So this will be covered under R, NPOWER, but it's good to note that no amount of tax is enough to cover the treatment caused by tobacco and now vaping epidemics. So I don't know why we are still not increasing the tax effectively according to WHO RCTC. So having all those numbers introduced to you, thank you. We now go to the clinical epidemiology, concept that I mentioned earlier on, So we put that into practice by, if you look at if you ask the question, how do you reduce prevalence? Of course, you can increase the number of deaths. By increasing the number of deaths from tobacco, you're going to reduce the number of prevalence. But there's a very bad kind of approach, like that all the smokers die earlier on without treatment, and they will die. You reduce the numbers. But we try to help them quit. And one of the approaches that has been considered as evidence-based is by introducing pharmacotherapy for smoking cessation. So in Malaysia, we currently only have the nicotine replacement therapy. Bupropion is available in certain places, but it's a prescription agent. So group B poison by prescription compared to at least gums and patches as over the counter. You can go in and buy without any prescription. Similar to the latest NRT product, the oral spray, which is a pharmacist item, non-prescription as well. So you can look at the relative risk or ratio to risk and all this in order to understand more regarding clinical epidemiology. When you look at studies and data on the pharmacotherapy, for example, because there's a dose response and also causal inference that I mentioned just now. We talk about active smoking particularly, but don't forget about second hand and third hand. More studies on third hand coming, but we have good data on second hand as well. So yeah, in summary, because of time, still dangerous. For clinical care, we'd like you to implement the evidence-based approach as in the WHO guidelines, also in our clinical practice guidelines, the 5 A's, the ask, advise, assess, assist, and arrange. If they are not interested, you can implement the 5 R's, which is listed here: relevance, risk, rewards, roadblocks, and repetition. I think there's a training program under scope to certify you to deliver both approaches, 5 A's and 5 R's. There are also other programs like the CSSP and now CSST if you want to become trainer on this as well. Because your role is multiple, from screening to educating, advocating, and so on and so forth. So we look at the case study for the closing. We're implementing the data. When you see a patient, you know the disease, and then you relate that as the risk to the patient and the rewards that they will gain. So you implement the 5 A's. Do note that advice in any form is impactful, especially if you are a physician. If you advise your patients, it has the highest impact. But it doesn't mean that only physicians can advise smokers to quit or vapers to quit. All of us can do that role. There are certain knowledge and skills involved. As I said, you can get it through certification programs so that you can assist them effectively. The diseases can be made individualized, relate that to the patient, the disease that they have. You may not know the numbers offhand, but you can look it up or ask your AI assistants what is the risk or what's the percentage, absolute or relative risk. And you can also relate that to the risk for the exposure to the family members. Yeah? So you can still get the numbers. Because sometimes when you deal with the smokers, they say, oh, it's okay, I'm not so concerned about my health. Okay? But they're more concerned about maybe their loved ones, like their family members, maybe not the wife, maybe the children or grandchildren. I've seen it in a few cases, so this is my experience. So assisting is the critical part, and then if we have the medication, then for this patient, it has to be evidence-based, so you need to go for combo of the highest form of the medication. Okay, so these are the steps that you need to go into or assess for the 5 A's. Okay, use the CPG. This Pakcik has launched it for earlier this year, so you can browse it and use the selection of the medication. As I said, this patient will fit the maximum combo dose. Okay, so you can explain to them how to use it, the technique, everything. This will all come with the training. Okay, and if they ask you about other type of interventions, you can discuss with them accordingly. Okay, and also don't forget, because smoking is a chronic relapsing addictive disease, you need to incorporate relapse prevention. Okay, and if they are also vaping, you need to know how to address it. Okay, using vape taper and behavior support, because we don't have any medications yet approved for vaping cessation. And if they are in any of the special population group, you need to know how to intervene a bit differently as well, because there are special precautions about this population. What more if they have psychiatric and substance abuse, and also risk of weight gain post cessation. So it's not as straightforward, yeah, but with training and practice, you'll be able to implement the data into practice, inshallah. Okay, with that, I thank you.